Good. Great. Thanks, Amy. Good morning. I wanted to thank all of you who are joining us here for the first time, and welcome back to those who have joined us previously for our special session of the Erie County Workforce Collaborative Training Series. The Erie County Department of Mental Health is happy to be able to offer these trainings to our dedicated providers in our community to support workforce retention and provide an opportunity for individuals from our provider community to share their expertise. Today, we are excited to have Christa Foschio-Bebak, JD MSW, Director of Quality Improvement and Training at CCNY, joining us to present on CQI 101. A few reminders here before we get started. At the end of this session, we will be asking you to complete a very brief evaluation form. We hope that you take a moment to fill this out so we can continue to improve this training series. Stay tuned for more information on our regularly scheduled training for July, which we are currently finalizing details on. We will be sending out announcements for this training in future sessions, or you can go to our erie.gov/mental health website for these announcements and registration information. All of our presentations and recordings for past offerings are posted on our website, so we'd encourage you to check those out as well. We are always looking for volunteers to share their expertise with our community providers. So if you are interested in doing a 1-hour presentation or interested in a particular topic, you can indicate that in the evaluation or contact Amy at amy.rockwood@erie.gov. Our training today is being recorded and everyone is muted. If you have questions, please put them in the chat box. I'll be monitoring the chat during this presentation, and Christa will take some time to answer these as we go along. There will also be a few opportunities to participate via the chat feature. Thank you to all of you for joining us today, and I'd like to introduce Christa Foschio-Bebak to talk with us about CQI 101. Thanks so much, Christa. It's all yours.
Great. Thank you, Kathleen. So I'm excited to be here today. As Kathleen mentioned, this is a 2-hour training. I know in the past they're typically 1 hour in length, but this is a pretty significant training. Typically, I do this training over 4 days, 6 hours at a time. So I am condensing this information to impart sort of a big picture overview lens of continuous quality improvement, while at the same time providing you tools and resources so that you leave today's training with not only new information, but also actual specific tools that you can use back at your organization. So I'm excited to be here. We'll get started. So a little bit about me. As Kathleen mentioned, I am the Director of Quality Improvement and Training at CCNY. I've been here with the organization for 15 years now. So it's gone by fast, but it's been an exciting, incredible 15 years. I have my degree, a joint degree in law and my master's in social work. Once I graduated with those graduate degrees, I spent time not only working in a micro level practice doing direct line work at Catholic Charities, but then transitioned over to Erie County Family Court, and then working with the entire 8th Judicial District throughout the 8 counties in Western New York. In that capacity, I did child welfare court improvement projects. So I was a liaison with the court administration, foster care organizations, Department of Social Services, and really tried to improve the way those child welfare cases were handled throughout the court experience. As I mentioned, I've been with CCNY now for 15 years, and in that capacity have been really providing technical assistance to not only county contracted organizations, but also the ability to provide more individual contracts with community-based organizations, helping them to implement quality improvement. So I'm excited to be here. As I mentioned, it is 2 hours. We will take a break if there's time. So I have allotted about 5 minutes for a break just to get up and stretch. But if there's momentum and folks are feeling engaged, we'll just plow through all of the information. So let's get started. So for those of you who are not familiar with CCNY, quickly what we do, we support health and human service agencies to integrate measurement, evaluation, and quality improvement strategies into their organizations. So we really come in and act as a consultant and as a guide, giving you data and evaluation, data and analytics to help support your quality improvement efforts. That way you all can continue to do what you do best, which is to enhance the quality of life for your members through your quality services. So CCNY does this in a couple of ways. We offer, as I mentioned, evaluation, analytics, quality improvement, targeted training, and also have a piece for grant management. So we're sort of always evolving depending on the needs and strengths of our community. So we believe that these particular departments really provide a robust, substantive, meaningful consulting guide for organizations, not only for our Erie County partners, but for also all of you as community-based organizations. So let's get into today's session. Our objectives, as I mentioned, we've got a lot to cover, but I feel confident that we can get through all of it. My goal here today is to sort of give you, again, a big picture view of what is quality improvement, why is it important, to distinguish between quality assurance and quality improvement, define some of the importance of quality improvement and key theories. So I'm going to go through a few QI models to support your quality improvement initiatives. So we're going to sort of get into more of an instructional piece around QI theories. We're also going to review organizational infrastructure needed to support quality improvement and effective quality improvement programs and processes. So really sort of giving you an overview of what you need within your organization in order to standardize your quality improvement processes and practices. We're going to take a look at identifying and monitoring relevant and meaningful outcome measures. We know that quality improvement is guided by metrics and having data and having outcomes. So we'll take a look at the importance of not only identifying those correct outcomes and process metrics, but also monitoring them. And finally, at the end of today's session, I'll guide you through using specific quality improvement tools and templates. So as you begin to identify which metrics are in need of improvement, the next step is to really use a guided process in order to implement a quality improvement action plan with tools and templates. So we'll review those at the end as well. So I always like to start with this slide. I think it oftentimes sort of kind of provides a chuckle as we get into this type of training. So quality, the race for quality has no finish line. So technically it's more like a death march, right? So when we think about quality improvement, it truly is continuous quality improvement. So why QI and why now? I would say over the past 5 years specifically, the push for quality improvement is really all around accountability. So there has been a shift that it's not just about obtaining and entering into contracts, but now the next piece of that is not only to enter into those contracts, but be held accountable to those contracts. And in order to be held accountable, there's data that needs to be monitored, that needs to be identified. And not only do you need the data, but then you need to do something with that data. Take proactive steps to respond to your data. And so doing quality improvement allows for that accountability piece to be more proactive in the way you account for your contracts and the way that you measure and monitor your outcomes. We know that competition for limited funds is out there, so you want to be your best, especially as we enter into value-based payment models, managed care contracts, and just overall marketing and value propositions for your organization and your mission. So what does this mean? Programs need to supply evidence of effective programs and processes. So in order to provide evidence that you are effective and you are meeting those outcomes, you need data. And you need to manage by that data. You also need leadership. And what I mean by that is that there is an organizational culture of improvement. that you're not relying on one person to implement quality improvement activities, but it's leadership at the top level and funnels down all the way to direct line staff. So it is a culture of improvement. In order to be effective, you need all of these parts working together. So the leadership, as I mentioned, effective service delivery systems and outcomes. If all of those three pieces are working effectively together, then you have a robust, meaningful model that allows for you to continue to enter into contracts with the county, with managed care, and so on and so forth. So again, if all of those three areas have the synergy and are working together, you will have an effective quality improvement model. You will continue to enter into viable, sustainable contracts that will really show your value and meaning to the community. So what is quality improvement? These three areas, data-driven, structured processes, and tools, all three of those areas are necessary in order to have a robust quality improvement system. Not only do you need these three areas working simultaneously together, but you also need what I already mentioned, sort of a continuous quality improvement management philosophy. So again, when we speak about quality improvement and its culture, it is embedded throughout your organization. It is your management philosophy. You're not just responding to audits or regulatory bodies because you have to, but you subscribe to continuous quality improvement throughout your organization. So again, it's this philosophy that it's meaningful, that it's woven throughout not only your higher up administration, but also supervisors and direct line staff. The other area of this slide that I want to highlight that's in red is that this underlying philosophy of continuous quality improvement is that when problems arise, it is generally a result of poor work process design, unclear instructions, or failure of leadership, not the people performing the process. Oftentimes when we think of, how can we improve, or if there is an outlier circumstance, or if there is a reactive culture within your organization, people tend to point fingers at a person. This type of philosophy or approach really says, wait a minute here, we need to take a big picture view, look at it through the lens of, is there something about the process? Is there something about the instructions, rather than pointing fingers at a person? The philosophy also behind CQI stresses the need for teamwork among all levels of employees and maintains that all employees are valuable members of the team. So again, as I mentioned earlier, quality improvement is not one person. While ideally it's best to have a position or a position that is a quality improvement director, AKA someone like me, it cannot be done solely independently. It truly does need the entire organization, an entire team, an entire stakeholder sort of model to implement effective quality improvement. So when you think about your organization and say, oh yeah, we have a quality improvement person, what I would sort of push is for you to think even further. What does that quality improvement person, role, director mean to me? And we'll talk about that in a little bit. So the objectives of quality improvement. So when we think of quality improvement related to your organization, obviously the goal is to facilitate the agency's mission, to ensure appropriateness of services, to improve efficiencies of services and processes, the effectiveness, to foster a culture of learning and teamwork, and obviously to ensure compliance with funding and regulatory standards. So quality improvement is really all encompassing. When you think of your agency mission, obviously you want to ensure that your agency mission is intact and is responsive to your programming needs. So when you think of your agency mission and the programs that you're offering, in order to continue to provide those robust, meaningful programs, we need to be constantly improving on them and monitoring their outcomes. So quality improvement, again, isn't just one person or one sort of one-off over here on the side of the organization, but it truly is sort of woven in through all parts of your agency, from the mission to your programs to your culture, and to be able to respond to your funding regulatory bodies and those who monitor your outcomes. One of the things that to keep in mind is that we know organizations often have compliance departments. So you think of a compliance monitor, you think of a quality assurance person, and those are all necessary and critical roles within the organization. But I show this slide and present this slide to stress that quality assurance and quality improvement are not the same thing. This slide sort of shows a continuum of activities, QA on one side, QI on another. Oftentimes, quality improvement can't exist without QA, and QA sort of allows for that structure around how to implement quality improvement. It allows for a starting point. And what I mean by that is quality assurance often already has regulatory metrics that need to be monitored. But the next step of quality assurance is then to do something when those QA type metrics are not being are not performing as they should. Or you have a regulatory body who comes in and does an audit to understand quality assurance type practices. And then there is a response, i.e. a corrective action plan. The goal here is to move from QA to QI so that you're continuously implementing quality improvement, so that should an audit come to fruition or a regulatory contract manager come to do a contract review or a site review, you are already proactively prepared because you've been doing quality improvement along the way. So quickly, when we look at the difference between quality assurance and quality improvement, I'll read from left to right, if that's how you're viewing the screen. So for example, quality assurance, the focus is on human error and identifying and eliminating outliers or poor performers. If you read to the right, the quality improvement focuses on systems first and individual performers second. Measures what your current processes are and creating systems to make things better, not focused on blamed. So quality improvement shifts from being reactive to being proactive. It also, quality assurance, as I mentioned, monitors compliance through periodic audits and inspections, where quality improvement monitors improvements in quality care through continuous review. So systems are in place in a quality improvement infrastructure, a quality improvement culture that is continuously reviewing your outcomes, continuously reviewing your metrics, rather than waiting for an audit or an inspection to bring something up. The last item, quality assurance, relies on following the rules and policies of the organization to meet the standards required by regulatory and accrediting bodies. Quality improvement, the shift is, relies on teamwork between different groups in the system, as those closest to the problem usually have the best ideas about the solution. So when you think of quality improvement and quality assurance, it's not that one is sort of better than the other. They both coexist, but it's what you do with the information. It's what you do with those metrics. Rather than waiting for an audit or an inspection, you are looking at quality improvement through the lens of a philosophy or a culture, that you have systems already in place to review your metrics, to review your programs in a continuous manner, rather than waiting for an audit. Here's a quick example when you're looking at this slide, thinking about QA versus QI. Quickly, you can tell by some of these remarks which one's QA or QI. When I do this in an instructional manner through a course, folks have an opportunity to sit down with a group. They have an opportunity to rewrite these statements so that they are more QI in nature. So you can see just very quickly the first item, which staff member failed to transfer the call on the correct extension. So here that particular statement is looking at as an individual person. Just the word or the tone of the statement failed to transfer the call, evokes sort of that QA type, oh no. And so I would say in that instance, that is an example of more of a QA type remark. The second one, are we creating an environment encouraging clinicians to report errors? This particular remark already you can tell lends itself to a more of a quality improvement lens. The idea that they're looking for solutions, that we're creating an environment, encouraging clinicians. All of those are more positive, more proactive words, purposeful, right? So we're not looking at one person, we're really trying to identify what is a systems approach to try and improving this particular area. The third one, how do we reduce data errors at intake? Again, evoking a solution-focused team approach. How can we improve? How can we do better? The next one, client had a bad outcome. What are the clinicians or case managers doing wrong? Again, that's that more QA, punitive in nature. So the goal here is many organizations I know already have compliance departments or quality assurance departments. I also know that many who are registered for this session are quality improvement directors or quality improvement managers. So I want to pause here to think about the last few slides when we think about quality improvement versus quality assurance. I wanted to open it up to any comments, questions, or thoughts, and you can input or insert those in the chat box. And some prompting questions here, does your organization do QA, quality improvement, or both? When you think about the difference between QA and QI, do you have a preference? Is one easier to implement than the other? Are there pros and cons to QA versus QI? This is some, just sort of thought prompting questions, but I'd like to sort of pause here and get your thoughts or comments.
We'll give it a minute and give people a chance to type in the chat. Crystal says our organization does both.
Great.
Brandon Robert also says their organization does both.
Great. For those organizations that do both, do you see, is there a purposeful connection between both roles, meaning they're working together, or are they sort of siloed into two distinct roles or two distinct departments?
Jennifer typed in that they call it QA, but they try to take more of a QI approach and should really rename it. Most people chatting in are saying their organization does both.
Great, great. So when we think about doing both and understanding or distinguishing between both, there is a reason to have a robust quality improvement and quality assurance department. And I think there is value in understanding and distinguishing between both of those roles, while also building an infrastructure or model that complements each other. And so we'll talk about that a little further down into the slides, ensuring that your organization has the infrastructure to support quality improvement framework, a quality improvement model, and what's needed to ensure that that's happening routinely in a very substantive, meaningful way. So let's move on. I wanted to pause here, or wanted to offer this slide specifically around understanding quality improvement and the history of continuous quality improvement. Oftentimes, people sometimes think that CQI, or this idea of continuous quality improvement, is something that someone made up along the way. You know, you don't go to college or graduate school, you know, to getting a degree in continuous quality improvement. And this concept or this idea of quality improvement is something that our funding sources or managed care sort of made up and sort of pushed down on us. But truly it is a solidified, an approach that's been studied throughout the years. The three folks who are on your screen now, William Schuett, Joseph Juran, and W. Edwards Deming, those are sort of three individuals who brought the idea of continuous quality improvement to the forefront, meaning they actually studied, they actually brought concepts and ideas forth to give it a more meaningful, substantive way of providing quality improvement infrastructure systems. And so I highlighted a few areas of what they're most known for. And so when we think of William Schuett, we think of invented control charts and the PDSA cycle. The PDSA cycle is something I'm going to focus on later on in the presentation. It stands for Plan, Do, Study, Act. Many organizations, whether it's healthcare organizations, community-based organizations, behavioral health, child welfare, are familiar with PDSA cycles because they're so easy to implement and do. So we'll talk about that a little later on in the presentation. Joseph Juran, I'm going to focus on for a couple of slides here, but his idea of this Pareto principle, the 80-20 rule that I'm sure most of you are familiar with, 20% of those processes that will get us 80% of the impact. Identify that 20% and begin the work to address those challenges. He also developed and put together this idea of the quality trilogy. So quality planning, quality improvement, quality control, that all three of those areas are necessary in order to have a robust CQI system in place. And finally, W. Edwards Deming brought the idea of PDSA into this widespread usage. So where William Schuett developed the PDSA cycle, W. Edwards Deming really applied it across systems. And so this idea of chain reaction of quality, improve quality, decrease costs, improve productivity, stay in business, provide jobs. He really thought of this as a systems approach to management of an organization. So all three of these individuals brought CQI to the forefront. That again, it's not sort of a made up thing that people say, hey, do something with your data, do some quality improvement, and throw some spaghetti on the wall and hope it sticks. No, this truly is a meaningful approach to improve your outcomes. I really want to just focus on Juran, specifically this Juran trilogy, and the idea that in order to have a robust quality improvement department or program, that you really are thinking about this whole systems quality. And whole systems quality means you're integrating quality planning, quality control, and quality improvement. And you're doing that amongst key social care system stakeholder groups. So it's not just one person who's trying to manage and coordinate this idea of quality planning, quality control, and quality improvement. Rather, you're bringing in different stakeholder groups within your organizations to invest in a quality improvement methodology. So it's not just, again, one person, it's across the organization, from your clients to direct staff to your board of directors. This slide shows how this can be implemented. So when you're looking on the right-hand side, there's your stakeholders, so your patients, families, clients, communities. There's clinicians, there's unit level leaders, your quality department staff, departmental leaders, executive leaders, board of directors. Each one of those stakeholders has a role in implementing this triology framework: quality planning, quality control, and quality improvement. So let me walk you through one. When you look at the quality department staff, you can tell that they have a role not only in quality planning, which they facilitate strategic planning, process, support research, and analysts in activities. They also have a role in quality control, support development of quality control, standard work, and infrastructure. What do they do around quality improvement? They support local QI activities and inform project prioritization efforts. The goal of this slide is to really show that quality improvement is infused amongst many different stakeholders within the organization. And truly, the only way to implement it effectively is ensuring that you have an organizational culture that embraces quality improvement by ensuring that each one of these stakeholder groups has a role in implementing and executing quality improvement at all levels. So when we think about these leadership activities that foster sort of this whole system quality framework, the idea here is that you have a cohesive and unified vision, that you're designing a process for all staff to know and learn and contribute to quality improvement. One of the things that I often hear is that if I ask a direct line staff, have you been involved in a quality improvement project? No, I don't have time to that. I don't know what that means to my role. I don't understand why is it important to me? It's giving staff the time and resources to be involved in quality improvement, allowing them to come to the table and simply asking them, what would it take to improve this particular practice? What would it take to improve this procedure so that we get better outcomes? Hearing from them lends itself to this whole system quality framework. So having the leadership up top emphasize that, support that type of collaborative feedback allows for a more meaningful quality improvement structure and allows for more meaningful quality improvement projects. The other item to think about and consider is this idea of practice systems thinking. So when we're thinking about practice systems thinking, the idea is that you are regularly reviewing data, that staff understand what that data means to their practice, that when you're supervising staff, you have data to inform the conversation, but you're using the data not in a punitive nature, not to say, gotcha, or what are you doing wrong? Rather, you're using the data to say, how can I help or support, or what ideas do you have in order to improve this particular practice item? So the data should allow for meaningful conversation. It should not be, I got your data, or a ding. Rather, it's data to help coach and improve. So this is that idea around practice, systems thinking, to understand that data isn't sort of taking one outlier event and saying, I gotcha. Rather, it's really offering data on a consistent basis so that direct line staff, program directors, supervisors truly understand the entire system, how they all interconnect and able to have a conversation around that, an informed conversation. Oops, sorry. The other items around these leadership activities that foster whole system quality is that you are demonstrating when you're having conversations with your supervisors, with your directors, with your administration, that you're allowing for collective learning and dialogue, that you're really there to listen and learn. Oftentimes, when we engage in conversation, especially around data, people tend to get, and it's a natural reaction, defensive, and try to find excuses to say, well, this is this, it's because of this, because of this, because of that, or deflect blame. Rather, we really want to allow for, hey, tell me about why this looks like this, and not only why this looks like this, but what can we do collaboratively, collectively, to improve our outcomes. So you're really listening deeply, you're asking questions, you're trying to understand the problems before pursuing solutions. And in order to do that, you have to invite that type of safe conversation around data and allow for people to say, you know, it could be because of X, Y, Z, but I think in order to improve X, Y, Z, we may be able to implement A, B, C. So allowing for that more robust conversation and in dialogue in a safe manner that allows for give and take. So I wanted to sort of focus on this idea of whole system quality, mainly because it really, in order to have whole system quality around quality, implementing quality improvement, it starts from the top down. And the leadership really has to embrace this idea of allowing staff to have the time, to have the resources to effectively implement quality improvement, to be involved in quality improvement projects, to give them training on quality improvement. If you decide or determine that the best quality improvement framework is to implement a PDSA cycle, giving training on PDSA cycles so that staff understand what it is in order to truly become involved and implement. So truly it is, when we think of continuous quality improvement, that culture of quality improvement starts from the leadership, starts from the top, and is infused throughout your organization. The next slide is a video, and I often show this video in our CQI course, because it speaks to the heart of quality improvement. This video is from the Institute of Healthcare Improvement, IHI. And this is, I say that to you because please note that and jot that down, IHI. It is a resource for you when you're thinking about implementing quality improvement. It has a tremendous amount of videos, templates, tools, examples. And while its focus is on healthcare, and this video will use healthcare terms like hospitals, physicians. In your mind, I need you to shift those words to organizations, clinicians, clients, rather than nurses or doctors or patients, because the message here is so empowering. So I hope you enjoy the video, and I will provide a link to Amy when she sends it out, so that if you want to use it in your organization to support your quality improvement efforts, it really is very, very valuable and very compelling.
Hi, I'm Dr. Mike Evans, and today's talk is on quality improvement, or QI, in healthcare. So I suppose the first question is, why should you or I care about quality improvement? I mean, to be honest, it sounds a bit boring. A CEO would have on her or his corporate objectives. But actually, if you dig a little deeper, it's pretty cool. Maybe more of a philosophy or an attitude about how to make something better. And now that I think about it, it's really the attitude I'm looking for in my patients. The ability and desire to tweak their habits, seeing if this change improves their life, and if it does, to try and make it standard practice. You see, for my patients to make these changes requires skills, but it's also an outlook. The humility and self-awareness to say, I've got room for improvement. The ability to gather better approaches, try them on, and see if they work, and then adapt them until they do. Well, if my patients can do that, I think they deserve the same from us in the healthcare business. So I suppose the next question is, if we have the attitude, how do we actually improve? How do we use QI to make care better? Well, the improvement business has been around for a while. Organizations like Toyota and Bell Labs and leaders like Walter Sheward, W. Edwards Deming, and Joseph Duran polished and simplified the science of improvement. And then along came a pediatrician named Don Berwick, and he wondered if we could translate the science of building better cars or electronics to healthcare. Dr. Berwick also wondered if there were lessons about systems we could learn from the kids he saw in his clinic.
The systems thinker is a perpetually curious person. Never thinks they have the whole answer, but is always willing to know what the next step is. If you watch a child, you'll see this happen. Children in their growth and development are innately systems thinkers. They're always trying the next thing. They're probing the material. They're listening to the noise. They're thinking about what the next thing to do is, and they're not in the job of solving problems forever. They're in the job of taking the next step. I think those are elements of what it means to be a system thinker. At the core of it is constant curiosity about a world that you will never understand fully, but you might take the next step to understand a little bit.
Okay, we've never dropped a vid into our vids, and Don is thoughtful, so I kind of thought it might improve our messaging. Let me know if you thought it did or didn't in our YouTube comment. Now, Dr. Berwick went on to co-found the Institute for Healthcare Improvement, or the IHI, and started focusing on the low-hanging healthcare improvement fruit, which is mostly reducing errors. For example, in Canada, a researcher named Ross Baker led a study in 2004 that showed of 2.5 million annual hospital admissions, about 13.5% were having adverse events, with 1 in 5 of those people dying or experiencing a permanent disability. In the US, the Institute of Medicine estimated that 44 to 98,000 people were dying from preventable errors every year. That's up to 4 jumbo jet crashes per week. Often these are errors we know how to prevent, but as is often the case, knowing what's the right thing to do and actually doing it are two different things. In 2006, Berwick and his colleagues challenged hundreds of US hospitals to bridge this gap and felt strongly that some is not a number and soon is not a time, and so set the goal of saving 100,000 lives in 18 months. They started with this simple notion: every system is perfectly designed to get the results it gets. So how do you change the result? Well, you change the system that produces it. Changing the system requires change agents, and in my province we launched Health Quality Ontario. HQO and orgs like it recognize that it's tough to balance proactive and reactive care in the field. But if they can help or incentivize or nudge us towards a more reflective practice and improve outcomes, we can actually create a better user experience for us all. Now, making this sound simple, like pushing a button, but getting people to change, even a simple behavior like hand washing, can be very complex and exasperating. But these seemingly small behaviors can have a ripple effect on health. A 2010 study calculated inadequate hand washing cost 247 deaths each day from preventable hospital infections, and that's just in the US. So let's jump back to simplicity. How to improve seems to boil down to 3 questions in a cycle. Improvement starts by setting an aim. So question number 1 is, what do you improve and by how much? So for example, we are going to get 70% of the staff to wash their hands before and after seeing patients by December 1st. Great, we have an aim. So let's start testing some changes, okay? Not so fast. Now you need to ask question 2. How will you know if a change is an improvement? We need to choose some things and measure them. What is doable and reliable, and that will tell us if the changes we are making are leading to an improvement? Is someone documenting doctor or nurse hand washing? Is it self-report? Is it the amount of soap and disinfectant used? Okay, we have an aim, and now we have some measures. Next up is question 3. What changes can you make that will lead to the improvement? To start, we just want to test one change with something called a PDSA cycle. Plan the test, do the test, study the test results, and then act based on those results. Maybe it's new soap dispensers or little bottles of gel. Maybe you read about the study that changed the signage from wash your hands to protect yourself to wash your hands to protect your patients, which resulted in a 3rd improvement over a 2-week period. Maybe it's reward or audit and feedback or asking patients to check. Just pick one and get started. Then you test other changes, and the PDSAs just keep rolling. Fine-tuning the change based on what you're learning. Saying to yourself, here are some ways we can improve. Let's try them out by dropping them into our practice in a thoughtful way that fits with our clinic and our patients. Now let's measure how we do. Adapt, adopt, or discard. Simple, right? But powerful, and it actually works. In my hospital, St. Michael's in Toronto, elderly patients with fractured hips were often waiting more than 2 days for surgery. This wait was painful, with increased chances of conditions like delirium, depression, longer recovery times, and even death. The care team scratched their chins, mapped out and redesigned every step of the journey to surgery in order to fast-track these patients. They created a code HIP, called as soon as the patient arrives. This streamlined them to the urgent list for surgery, rapid triage, essential testing, priority consults from anesthesia and internal medicine, and so on. All these tweaks led to a jump from 66 to over 90% having surgery within 48 hours. Now, these changes don't happen without engaging the human side of change. One thing you'll discover is that it's possible that the people you work with might not be as into hand washing or urine infections or diabetes as you are. I know, crazy, but this leads to 3 pieces of advice. First is the concept of innovation fatigue. Often your workmates are getting overloaded with requests for practice change, which are well-intentioned but can be overwhelming. My own approach is to take a page from motivational interviewing. MI recognizes some of our natural inclination as problem solvers is to fix things, provide advice, and argue for change. But the reality is that not everybody is ready for change. Both MI and QI recognize that ambivalence about change is normal, that building readiness and confidence for change, a shared agenda, requires careful listening and strategic questioning, the ability to roll with resistance, more of a dance than a directive, I would say. Actually, sometimes resistance to change can actually be an opportunity in QI. Creating diversity or disruption can actually be an opportunity, something to build on. My second point is about priorities. I think we have to acknowledge that patients and your fellow clinicians may have certain priorities on the day. That talking about depression or headaches may trump your diabetes flow sheet, or even that focusing on their non-diabetes issue might in fact be more helpful for patient self-management. Reshifting sands to the transition from silo care or the reality of the emerging science of complex care. Sure, asking what's the matter, but also asking what matters to you. A great example is in Timmins, a small town in rural Ontario, where they wondered if they could do a better job of handling complex patients in the emergency department. So people seen in the emergency more than 14 times or admitted more than 3 times a year. They started with standard assessment tools, identified diagnoses and related problems, generated care plans, but unfortunately, patient use didn't decrease. The team then flipped their approach to what's called patient discovery, where they identified health and lifestyle challenges from the patient's perspective and combined that discovery with motivational interviewing techniques. This new patient-centered approach resulted in more than an 80% reduction in emergency room use and admissions. Finally, after having done many interventions, my mantra is, how can I make it easier to do the right thing? Maybe easier is about sharing the load. At Kaiser Permanente, front desk staff can actually check and book for preventive screening. Everyone can help in QI. All these point to the softer side of good quality improvement. That when we look at the science of innovation, it's less about big cognitive leaps and more about agility, small incremental steps that build on the ideas of others and engage our own genuine curiosity regarding what motivates and inhibits the individual and system's path to change. The main point is, start. Find something you can improve and get going. Look, it's hard to summarize improvement and not get into bumper sticker territory, but I would advise not to let what you can't do stop you from what you can do. It's time to entertain complexity, but focus on simplicity. Asking yourself, what can I do by next Tuesday? Have a meaningful needle and test some changes to start moving that needle towards an important goal. Hope this helps, and thanks.
So I just want to pause there and give people an opportunity. Any comments or thoughts, feedback about any takeaways from the video?
It was good, someone said.
Okay.
Engaging and informative. I like that it touched on the human side of change too. Our department is going through a lot of changes, so I can identify with the information. Excellent video, great video.
Please, 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 I will include the YouTube link. So I sometimes think that when you're talking about particularly the comment around the department is going through a lot of change, or that he mentioned the fatigue around, implementing quality improvement, fatigue around changes, meeting fatigue. Sometimes just bringing the team together and perhaps just showing this video so that people have an opportunity to sort of take a breath and say, okay, this isn't just us, this isn't just me, this is a normal reaction around change and implementing change. This type of video allows for that type of discussion. I would also just recently, I can share an experience, when my staff and my team came to me and actually said, our stakeholders and our collaborators are feeling meeting fatigue, meaning that my goal in my role in my department is always implementing quality improvement initiatives, quality improvement projects, quality improvement action steps. And so sometimes I have to be reminded to say, hey, Christa, take a pause. Let's regroup. Let's see where people are at in terms of their motivation, in terms of their excitement. Because there is some value sometimes to just take a pause and evaluate where we're at, and look at past QI projects and see how those are continuing to evolve, but just really being aware, mindful and aware of where your team members are, where your stakeholders are. He had also mentioned that readiness for change and sort of having a pulse on people's state of readiness to implement new quality improvement projects, to implement new changes. And so if you are a director of quality improvement or compliance or QA, that is a dance. You're not just sort of facilitating quality improvement plans or corrective action plans, but you are truly mindful of where people are at in terms of this quality improvement journey. And so I think a video like this and bringing people to the table to view something like this allows for that opportunity to have a conversation around some of those soft skills and where people are at.
One last comment that came in was that they liked the statement, how can I make it easier to do the right thing?
Yes, that is the goal in any quality improvement project. We're not trying to overcomplicate. Rather, we're really trying to look at those processes and find some more practical and efficient action steps. So sometimes less is more, for sure. Oops. Okay. So in the video, he talked about PDSA, Plan, Do, Study, Act, and that is a model for quality improvement. So for those of you who have quality improvement departments, I'd like for you to think about what your model is. So when you implement or institute or execute a quality improvement plan, are you using a particular model? And there are many models out there. So there's Six Sigma, which the county subscribed to in years past. There's what I mentioned, PDSA, there's Focus, there's PDCA. The idea here is that each model has similar stages and similar tools. But as a community-based organization who is implementing quality improvement, the idea is that you subscribe to one. That your quality improvement model is written and documented, that your organization, that the culture of your organization knows what their QI model is. So if you were to ask a direct line staff, a caseworker, a care coordinator, hey, when you implement quality improvement, what model do they use? Or what structure or approach do they use? What framework? They can say, oh, we subscribe to PDSA. So the idea here is that there really truly is a robust framework that your organization implements and follows. Here's a quick overview of some Some of those models, FADE, PDSA, DMAIC, which is Six Sigma, Focus, or PDCA. You can tell that there's some commonalities or common threads amongst all of these models. The idea is to first identify an issue to improve, analyze it, use your data, implement changes or quality improvement action steps or strategies, and then review. Did those strategies or did that action plan actually work? Did you get better outcomes as a result of implementing that QI plan? Okay, just checking my time. So the other thing I want to mention too is that when you're considering which QI model you're going to implement, that you have the infrastructure to support that. So again, you all mentioned that you have QA departments or QI departments, that you may have directors or department leads whose responsibility is to implement and execute quality improvement plans. So when we think about your organization and your infrastructure, we really have to understand that in order to have a high quality organization or a high quality social care organization, that all of these bubbles, if you will, that are on this slide are interacting at the highest level possible. So quickly going through, you can see you have the leadership that provides role models who sort of emphasize and support the QI learning. Your culture allows for every department, every staff to participate. You have data and information to support improvement, that again, you're not just throwing spaghetti on the wall and saying, hey, I think let's try and improve this and see if it works, that you're really using your data to inform your quality improvement initiatives, that you have communication channels so people understand and know what QI project they're working on, whether or not you are in fact able to achieve those outcomes that were intended, that you have strategies and policies, so that you have policies and procedures and expectations in place on how your organization implements quality improvement, that you have resources, so that time and space to allow staff to coordinate and to be involved and participate in QI initiatives, that you have skills and training, that staff know what quality improvement is, that they know how to execute a PDSA cycle if that's the model you choose, that you have clinicians and workers who are able to participate and plan in the QI initiatives. So all of these areas are working together. And so when you look at this slide and you think about your own organization and what you do to inform your quality improvement projects or to participate in quality improvement, do you have all of these items in place to ensure that you're continuously applying quality improvement throughout all programming levels? The other area I want to focus on is this idea of this infrastructure. So what is needed for QI? And I had quickly sort of alluded to this idea that if you do in fact have a quality improvement department, that you have a written CQI plan. So you do in fact have policies and procedures intact in how you implement quality improvement in your organization. You have forms and templates available. You have data sources available. You have processes and communication structures in place in order to support continuous quality improvement. I mentioned early on in this presentation that a dedicated position is best. That's great if you have one person, but they cannot be the only person who is implementing and executing quality improvement plans. So when we think about having a dedicated position, absolutely there should be clear expectations and a description of that role and responsibility for management of QI processes. But also, if in fact you have a QI culture and infrastructure in place, that dedicated position is supported by other people who are able to actively participate in QI plans. The other idea, obviously, is that you have available data, that you're able to consistently review that data and monitor that data. We talked about this idea of agency culture, that it is supportive and open to change. It's strength-based, not punitive. And this idea of using committees and stakeholders, that one size does not fit all. So when you're thinking about implementing a quality improvement action plan based on a particular program or a department or outcome measure, that committees are put in place and they represent workers and stakeholders of what is being improved upon. So I mentioned earlier, when we're thinking about your internal stakeholders and when you're considering and thinking about committees, that everyone within the organization has a place for quality improvement, that the board is aware of what quality improvement initiatives you are undertaking that quarter, that year, that they are reviewing that quality improvement project and understanding whether or not it was able to successfully achieve its outcomes, that the administrator is aware of QI plans that are happening throughout their program levels, that supervisors are actively involved in QI plan development, that they take an active role on that QI committee or project, that frontline staff are asked to come and participate in a QI project for lots of reasons. Not only does it inform the QI plan, but they also have direct knowledge of what works and what doesn't work, but it creates buy-in, that when you go to implement your QI plan, if it is successful, you have frontline staff who've already bought in because they were a part of that QI project initiative. When we're thinking about your quality improvement infrastructure, there are certain examples. Here's a sample of what one could look like. So if you have a QI committee, so if your organization has a quality improvement committee, that QI coordinator or project reports to that QI committee. So they allow for that communication between the QI committee and those project teams. When we think about internal stakeholders, that staff from all levels of program or organization, including HR, finance, direct care. If you think it would be important to have an HR representative on your QI team because perhaps one of your strategies is to recruit new staff, you might want them there from the beginning. If you think it's important to have a fiscal person on that QI project team because it's going to mean more training, and so having the dollars available for professional development, it would be important to have that finance person on that QI team. So when you're thinking about your internal stakeholders, really consider who needs to buy in, who has the information to support particular QI initiatives. If you don't have a dedicated person or a separate committee, it could be that you have an admin or a leadership team, that perhaps your program manager or supervisor are sort of designated as leading a QI initiative. So that program manager or supervisor would have QI project teams that they would then report back to the leadership team. So the whole goal here is that you have a robust QI infrastructure in place, that this becomes a part of your policy and procedure around how you operate in implementing quality improvement. Another example of how this could look. So the idea here is that you have your agency or department QI program, that all of your documents and templates are in place and how you execute QI projects. And if those two items are in place and it's very structured and very purposeful, you have a more robust quality improvement infrastructure in order to achieve quality improvement outcomes. So the whole goal here is to think about, does your organization have a QI model? And what I mean by that, do you subscribe to PDSA? Do you subscribe to Six Sigma or Lean? Are you aware of what your QI model means to your role in terms of, do you participate actively? Are you aware of QI projects? Are you aware of the activities that are happening around those QI projects? Have you in fact participated in a QI project team? So I want to pause here and for all of you to sort of think about these prompting questions. When you think about your QI internal infrastructure, do you think about, oh yes, I've seen it. I've seen it in our policy and procedure. Yes, I know what it means that there are active committees in place, that I've actually participated in a QI project team. So I open that up for comments or thoughts.
Someone did type in a quick question. What was the name for the QI models again?
Sure. So they are, I can take you right back. There are models like Plan, Do, Study, Act, PDSA. CCNY subscribes to that model. So when I provide technical assistance or I'm working with a particular agency, I walk them through on how to implement PDSA. There's something called DMAIC, which is your Six Sigma. So define, measure, improve, control. There's something called FADE. There's also another, some people say, if you're familiar with results-based accountability, RBA, some of the ideas in RBA are consistent with QI activities. So these are examples of models that you would use to implement your quality improvement projects.
Another question for you that came in. Can you explain more why it is important to follow only one model?
So if you are using different, many of the models, and I'll give you something like Six Sigma. Six Sigma is very, if folks are familiar with it from years ago, very manufacturing in its context. The language and words it uses, like widgets, or the technical processes it refers to, may not be conducive to your mission, your culture. And so thinking about choosing a model that not only that uses the correct language or uses templates or activities that sort of fit in with your organizational culture will help to ensure that you're being very consistent and methodical in how you're implementing QI projects. Something like Plan, Do, Study, Act, PDSA, is intended to be sort of what they call sometimes as a rapid improvement cycle. So it allows for teams to quickly implement strategies and quickly determine and decide if they are working. And if they're not, then you sort of abandon and you go back to the planning stage. So when you think of particular models and you do research into what it's going to fit within your culture, I would say it is important to choose one rather than sort of going back and saying, okay, we're going to use DMAIC for this, or we're going to use PDSA for this project, or we're going to use RBA for this project, really trying to focus in on what makes sense for your organization and what it is you're trying to improve.
And then just a few comments. Joanne said she's the Associate Director of Training and Staff Development with Endeavor, and she is on the QI committee. Christina said, we do not have them, but we need to have them take place. And Crystal said they use DMAIC.
Okay, great. I can't say enough when you go back to your organization, regardless of which role you are, if you're here as a director, if you're here as a program manager, if you're here as a QI person, director, or if you're here as compliance, to really go back and look at your policies and procedures, or go back and look at your employee handbook and see if there is in fact a placeholder for how you implement quality improvement within your organization. If there isn't a placeholder, or there isn't a policy around that, and there isn't structured processes that allow for purposeful, meaningful QI, I would bring that back to your administration and say, hey, in order for us to do this consistently in a meaningful manner, it's worth it. It's worth it for us to sit down and really think about how we're going to execute quality improvement moving forward. Okay. Oops. Okay, so I've already sort of alluded to the idea of that, ensuring that you have a quality improvement infrastructure in place by making sure that it's written down, that there's a policy around it, that there's a procedure and expectations around how you're going to implement QI. And part of that is not only ensuring that you have the structure in place to support committee work and QI project work, but also ensuring that you have measures and outcomes that you are routinely reviewing. Because without that data, I keep alluding to this, you're just sort of throwing spaghetti on the wall. That data, those outcomes and those measures and those metrics really set the tone of how you're going to implement quality improvement moving forward. So I'm going to take a look at, talk a little bit about ensuring that everyone is aware of which metrics and outcomes are important to measure on a consistent basis in order to implement QI. I've already talked a little bit about this before I get into the metrics and the outcomes. When you're thinking about building your policy around QI, obviously ensuring that you have roles and accountability, responsibility, who needs to be engaged in quality improvements, whether they're internal or external stakeholders, details of your structure, communication flows. And so when you're thinking about this organizational infrastructure around supporting QI, you're going to think about how it actually looks. And so I know there was a comment that, we don't have committees in place, and we think that somebody might be doing QI over here, and sometimes we may hear about it, but the goal here is to really have a consistent way and a consistent method in which you're executing quality improvement. And so, something like just a quick visual or a workflow around who is expected to be a part of these QI teams, what type of data we're going to review on these QI teams, how often, in what format, how we're going to communicate with one another. So just mapping it out is a good way to start if you don't have in sort of a written guide in place already. What I wanted to focus on for this particular presentation, though, is the idea of ensuring that you have measures and outcomes that you are reviewing on a consistent base. So working with your QI team, so if you are a director of quality improvement or compliance, and I'm sure at this point all of you who are in that role already know what your data sets are, what it is that you're monitoring on a consistent basis. But for those of you who are sort of entering this idea, rather than waiting for what metrics are subscribed to you based on an audit, really thinking about your agency mission, your program outcomes, and what it is that you should be monitoring regardless of what an auditor tells you to do. So when you're thinking about defining and measuring your data, obviously it should align with your strategic plan and mission, but you're going to think of data sets that are related to fiscal and HR, maybe maintenance or IT. For sure, you're going to be looking at data sets around quality of service delivery. You may be looking at customer and worker satisfaction and meaningful outcomes around those programs. You want to look for clinical improvement, functional status improvement, health, safety, welfare, quality of life improvement. So identifying metrics that inform those areas. Looking at how that data is collected and how often, you're going to consider what types of benchmarks you should have in place for those data sets. So putting in benchmarks is what you desire, what you want the result to be, so that when your QI committee comes to a meeting, they have if you will, a dashboard, a quick dashboard that says, hey, we're missing the mark on this particular outcome around functional status improvement. We want to be at 70% or 75% or 80%, and we're at 50%. That allows the QI committee to know, okay, we need to implement a QI plan. Some examples of operations measures. So you're going to be looking at things like staff retention, so turnover rates. You may be looking, if you're coming from a facility, staff injuries, number of injuries that led to worker comp claims could be one example. You might be looking at employee survey responses, so satisfaction and benefits, workplace satisfaction. You may also be looking at financial performance. So, net revenues, comparison of budgeted development revenue and actual development. So these are types of operation measures, right? So if you have a QI department, you may have within your QI department folks who are designated only to look at sort of those operation measures. And maybe you have another person who's designated to look at measures that are related to program outcomes. But the idea, my point is that you do have identified measures that you're looking at on a consistent basis in order to prompt QI initiatives. Examples of quality service delivery measures. So you're looking at risk management data, client record review data, program output data, client survey responses, stakeholder survey responses. So you can go back and look at this PowerPoint and sort of drill down. These are just examples. Again, I'm sure based on who was all here, you have a ton of data. So it's really beginning to organize that data in a consistent format that you're reviewing, on a monthly, quarterly basis in order to prompt QI initiatives. Again, the goal here when you're thinking about quality improvement is you are being proactive based on the data that you are reviewing on a consistent basis. And again, you're reviewing it on a consistent basis with the committee because you already have the infrastructure in place to support how quality improvement is delivered. Some examples of client outcome measures. So we're looking, these would be based on your programs, your individual programs. So improvement in life schools, number of clients securing employment. If you have an educational program, you're looking at school grade progression or graduation results. You may be looking at HEDIS or CAR measures based on that particular program. So again, these slides are just intended to prompt, what it is that we are collecting relative to initiating QI projects. Your other areas, so we talked a little bit about making sure that when you're thinking about your quality improvement infrastructure, not only are you looking at review of consistent metrics, but you're also defining, okay, once we've reviewed these, what are we going to do? How are we going to utilize quality improvement? And as I mentioned, you would be describing your describing your model, whether it's Six Sigma, PDSA, or something else. Describe the data collection tools used. So which data are you going to use in order to understand whether a quality improvement initiative needs to be implemented? Describe expectations for data collection, who does it, how often and when, and describe communication flow. So these last few set of slides is really intended to give you information and give you a framework around when you're implementing quality improvement, that your model includes the structure of the QI program, which measures and outcomes you're monitoring on a consistent basis, and has operations and procedures written out that are standardized that you will follow as you execute QI plans. So again, just a quick pause when you're thinking about these last set of slides and how it's related to your role and how you inform and execute QI. I'm sure and I'm hopeful that your organizations already collect routine data. And if so, is it reviewed in a structured, consistent format? How do you know when to take proactive QI action? So these particular prompts, if you are able to answer them, I would say then you do in fact have an infrastructure in place to support quality improvement initiatives. If you're sort of hesitant and saying, I think we look at data when someone tells me that there's a data point we need to improve, but I don't know if anyone's looking at a set on a consistent basis, that may give you some pause to say, we might need to double check with my team or with my administrator or director. So I just want to, again, an opportunity to pause. here if there's any comments or thoughts or questions around your infrastructure and how you review data, if it allows for a structured process. Do you know when to take proactive QI action, or do you sort of wait for someone to tell you?
We have one comment that came in. Yes, we collect data and review the data within the committee and at a leadership level.
Okay. And then my response to that would be, and then once you review it, you do something with it, meaning if it warrants a quality improvement initiative, you would go ahead and start forming a QI committee to address that particular data point.
She said yes, correct. Another comment that came in, need to take a more focused approach to move from a QA approach to a QI approach.
Okay, great. I'm glad you're able to recognize that. If there's any takeaways from today's presentation, the idea here is that you're not waiting for an audit, you're not waiting for a contract manager, you're not waiting for a regulatory body to tell you have to do something and that it warrants a corrective action plan. Rather, you have the infrastructure in place to support continuous quality improvement, so you're proactive and consistently looking at the data. So,
just a couple last comments.
Sure.
Yes, we collect, review data, determine if it meets benchmarks. If not, we initiate QI efforts.
Great.
And then another one, we review data consistently too. We have goals assigned at a national level. My department also sets our own goals as well.
Great. Great.
A few more comments. Excellent point. While some members of our team could answer the questions, I don't believe that all staff in all roles could. And another comment, our team has bi-weekly supervisions to discuss daily tasks, monthly team meetings, quarterly reviews with senior leadership. At all points, we have the opportunity to identify and plan for proactive action.
Awesome. You know, it's great to hear all of that. And for those of you who are implementing quality improvement plans on a consistent basis, as you achieve those quality improvement plans, I hope you're able to recognize those efforts and, so, if you will, quote unquote, market them across your agency and celebrate, hey, we were falling short in this particular area. We implemented a quality improvement action plan. These were the steps we took. And as a result, we went from 50% to 85%. And so when you have a robust infrastructure in place, it allows for your organization to understand what maybe these smaller QI committees are doing and allows them to celebrate their successes. And so when you're thinking about your infrastructure and what it is you do to implement quality improvement, think about the end game too, really sort of celebrating those successes once you have a successful quality improvement project come to fruition, if you will. Okay, great. All right, so I'm not going to give us a break, so I apologize for that. We're at 10:25, and I wanted to give you guys an opportunity, or I wanted to give you some templates. So for those of you who are utilizing a quality improvement framework or already have your infrastructure in place, think about what templates or what tools or what resources you routinely use when you're implementing your QI project. So is there an expectation that when a QI project is implemented with a particular committee or action team, that they are guided by templates? And I'll go through them, but there's an expectation that they will do the PDSA cycle. And if they're using the PDSA cycle, they will develop aim statements and use driver diagrams and use process maps or journey mapping. That all of these types of quality improvements tools lend itself to an effective quality improvement plan. And so I'm going to go through a couple of templates and examples. So you have some takeaways if there's some new templates or resources you want to try, or if you're only just now sort of thinking about how you want to organize your QI efforts, you could use these as a way to begin to create your infrastructure around quality improvement. So again, CCNY subscribes to the PDSA model, Plan, Do, Study, Act. It's a fairly easy, quick model to implement. There's 4 stages. There's the plan stage, which allows you to define the problem based on your data. So if your data shows that you're falling short based on a performance report or a dashboard area, this allows you to say, this is the particular item we're going to improve. And now we need to understand why we're achieving lower benchmarks, if you will. So what do we need to, how can we understand the problem in order to execute a QI plan? The do stage is when you're actually implementing your action plan. So who will do what by when. So this allows for you to implement some newer change strategies. The study stage allows you to identify whether or not those change strategies are in fact giving you better results. And if so, if you are in fact getting the results you intended by implementing those new change strategies, then you act on them. The idea of the PDSA model allows you to sort of pilot a small change. And if it works, then go ahead and act and spread out either to the rest of the department or rest of the organization. The PDSA model also allows for you to have what I call, and I alluded to earlier, rapid improvement cycles. So if at any point during any one of these stages, particularly the study stage, if you're finding that these change strategies that we identify during the do stage aren't working, it allows you to go back to that do stage or the planning stage and say, what do we need to change? So you're not waiting around for months on end for you to reach your target. Rather, you're sort of consistently evaluating by using this model and using the study phase to say, not quite making the mark, let's go back and reconvene. So I did already go through the PDSA. You're planning, you're recognizing an opportunity to change, you're doing, you're going to test the change, you study the changes to see if the data does in fact show improvements are happening, and if so, then you act on it. When we're thinking about our planning stage, we're always planning with the team. And I keep going back to this because I know there are many quality improvement directors or supervisors or administrators who act as the quality improvement person across the entire organization and multiple programs. While it's important to have a champion, it's also important to have a team behind you. So make sure when you're implementing a quality improvement initiative or a QI project that you have the right team. When you're planning with your team during the P stage, you're really trying to predict and plan with a concise statement what it is you're trying to improve. So this is also known as your aim statement. So when we think of an aim statement, here's an example or a template that I will share with both Amy and Kathleen. So if you don't have sort of, okay, our first step is to plan. And when we're planning, we need to make sure we have an aim statement. Here's a template that will help guide your team to ensure that you have a robust, structured aim statement. So what is the opportunity or problem? How much do we want to improve upon it? How good do you want to get? By when, for whom, and where. So in this example, increase the percent of children who receive a health needs assessment. By how much? 95% of children who should receive a health needs assessment will receive one. We'll do this by January 31st, 2020. For children under the age of 12 who have an initial referral to Child Protective Services, where in Middlesex County, etc. So it really allows for you to operationalize your aim statement. It's not a big pie in the sky, broad statement. Rather, it's very operationalized and concrete. So a template like this will help sort of help your team in making sure that the aim statement that we're trying to improve upon is in fact concrete and substantive. Another example, and I'll again provide this handout too, to Kathleen and Amy is this one allows for more deeper dive around your aim statement. So for example, number 2, intends to accomplish. That particular area allows for a deeper dive of the team to really think about it, what it is that they're trying to achieve, but has similar components. Item 3 gives you a time by, by when do we hope to accomplish this, for what group, because in this particular template allows your team to say, why do we think this is important? So these type of templates really guides the team in ensuring that, okay, what is it specifically that we're trying to improve? The other area to think about when you're in the P of the PDSA cycle is not only ensuring that your team has a robust aim statement that ensures what it is you're trying to improve upon, but now you need to understand why. Why is this even a problem? Why are we not achieving our targets or our benchmarks as we thought? So you need to take deeper dives. And there's lots of ways to do a deeper dive and really truly understand the root cause. And you can use logic models, SWOT analysis, journey maps, 5 whys, process maps. Today, very quickly, I'm just going to review the fishbone and driver diagram. So for you QI directors or administrators, you're probably already familiar with the fishbone diagram, especially if you implement a DMAIC model. Fishbone is also known as an Ishikawa diagram, which comes from Six Sigma. So if you're doing DMAIC, you may be familiar with this. And driver diagrams are sort of a newer tool in the quality improvement field. So I wanted to give you some newer activities and newer templates to utilize. So when we're thinking about a fishbone, again, we're trying to understand the problem. So we're in the P stage of plan, do, study, act. And the P stage is that you're planning your QI project. And when you're planning your QI project, not only are you developing a concrete aim statement, but you're also trying to understand the root cause. Why are we not achieving what we thought? So this is sort of a neat visual way to bring the team together to understand the root cause. So it captures many different ideas from your team, allows for brainstorming. You can use it in a group setting, and it really allows for exploration of the issues behind the problem. When you construct a fishbone, it truly does look like a fishbone. So you have the head of the fish, and then you have bones coming out of the fish, and those are sort of all of your reasons, your brainstorming reasons as to why you're having a challenging area. So when you think about creating a fishbone, you always state the problem in the form of a question. And so that form of a question becomes the head of your fishbone. So for example, why do we have higher rates of employee turnover? Why are we missing opportunities to improve employee engagement or joy at work? But the team should agree on what that statement problem is. And then the rest of the fishbone consists of the lines or the reasons as to why we think we're not where we need to be. These lines, or bones, if you will, often end up being grouped into different categories. So you'll have headers on each of the, and I'll show you an example. I know you're following my hand and thinking, what the heck? But you'll have headers on each of the bones that are coming out of the fish. And sometimes these categories or headers, if you will, can be grouped as policies or procedures, people, material, method, measurement, human factor. And so when you're creating this fishbone with your team, if you've already done some research prior to meeting with your committee, you may in the back of your head already know, I have a feeling a lot of the reasons are going to be grouped under policies. You might already want to put those headers up there. You can go ahead and do that. Or you can choose, you know what, I'm just going to have a free sort of conversation and let people brainstorm ideas or reasons. And then you can go ahead and group them in each bone as they evolve. So let me show you how this looks. For example, why do we have high employee turnover rates? So as people are brainstorming different reasons, they become grouped into different categories. So I'll read the lower one under personnel. work schedule does not match jobs needs, lack of encouragement and recognition, lack of trust and effective collaboration, lack of growth, no sense of achievement, lack of clarity. So all of those brainstormed reasons become grouped under personnel. So it's a way for you to generate discussion with your QI plan in a very sort of structured way. By doing this, you now have all of these ideas. And if you do it on a Post-it board or on a wall, you have sort of all of these ideas that people can, or reasons that people can wrap their heads around. Going, now I get it. You know, these are all of the possible reasons. And you can talk, you can now have more of a substantive conversation with your committee. You know, can you eliminate any ideas that everyone agrees would not really cause the problem? Well, yes, that's a problem, but probably it's not the root cause of the problem. You can examine each idea and determine the degree to which the idea is an actual cause of the problem. I've seen other agency or other committees say, you know what, we need to start somewhere. So let's start with this category because it's low-hanging fruit. It's something that we can quickly get our heads around. We can quickly implement a QI plan around and gain some momentum. So sometimes it just allows for you to prioritize where we want to start. But the idea is start somewhere. Another resource for you to use when you're thinking about planning for your quality improvement project is the use of driver diagrams. Again, you would use this tool or this template during the planning stage of the PDSA. It's another visual that allows your team to have a more substantive, structured conversation around all of the factors or drivers that influence what it is you're trying to achieve. So again, it's another way to organize people's thoughts and ideas around how to implement your QI action plan. Driver diagrams look like what you see there in yellow. You can tell I'm a fan of boxes, so I like everything to sort of be neatly organized and categorized so I can really truly understand the system or what it is that or the process that we're trying to improve. So by doing a driver diagram, you're able to take the aim that you've already created with your team and input it into the larger box, so what it is that you're trying to achieve. The second part of a driver diagram is sort of, it shows the relationship between the overall aim of the project and all of the drivers that contribute to achieving that aim. So the next set, or the next column, if you will, are your primary drivers. And those are the primary drivers are those drivers that are sort of non-negotiable. They need to be in place in order to achieve that aim. And then from there, you would go to your secondary driver column, which allows for, okay, what are all the processes or practices that are connected to that primary driver in order to achieve that aim? Once you're able to sort of map that out, you can then attach change ideas to those drivers. Again, this allows for people to sort of see the big picture written out in a very sort of neat, concrete format. So when you're using this in practice, you literally are going up to the board, if you have a board or if you have a Post-it paper, and drawing out a box that includes your aim statement. You're then drawing lines or connectors. What are those primary drivers that we need in place to ensure that we can achieve this aim? And you're working with your team through that. From there, you're connecting those secondary drivers, those current processes or practices that are in place. And because we have those current practices or processes in place, are there opportunities to change any of those in order for us to impact the primary drivers so that we can achieve our aim statement? So it really truly is a way to facilitate and guide conversation around developing QI action plans. How to develop, again, you're working with your team. You already have your aim statement created. You might want to look at, I can't say this enough, if nothing else, oftentimes when I work with quality improvement teams, you will hear their aim statements, and after a while they sort of maybe begin to sound familiar. Maybe it has something to do with intake. Maybe it has something to do with scheduling first face-to-face. Maybe it has something to do with creating or ensuring that plans of care are updated on a continuous basis. There are other QI, I'm pretty sure that if you were to do some research before you met with your committee, you would find that other organizations across either New York or across the country have developed QI plans around these particular aim statements. So go ahead and do a research, best practices around intake, best practices around creating plans of care. And you may spur some ideas that you can bring to your committee when you're executing a driver diagram. So, really thinking about reviewing the relevant information and bringing it to the table and bringing it to the committee to have a more robust conversation around it. Avoid perfection. I already talked about visualizing it, drawing it out. The mere act of getting up and using your hands, I think, allows for people to be more engaged and motivated in the conversation. So don't underestimate, the power of a piece of paper and a pencil and a marker and getting up and drawing things out. Here's an example, one sort of a silly example, but I think it gets the point across. The aim statement here, how can I reduce my BMI to 28 or lower by whatever date. So the primary drivers in order to do that are my calories in, my calories out. What are the secondary drivers that inform my primary drivers? So calories in, prepared meals, alcohol consumption, protein, carbohydrates, consumption of sugary beverages. And then you can see as you move to the right, they begin to identify interventions that will impact those secondary drivers that will then hopefully inform their primary drivers so that they can, in fact, achieve their aim statement. So I know that's sort of a silly kind of driver diagram to think about, but I think it's clear enough in that it's very specific on how to think about your aim statement relative to primary, secondary, and interventions. Here's another example, and this is the worksheet that I will send to Kathleen and Amy. Here's an example of an aim statement. Improve employee retention by X, and then you could also include by when. So the primary drivers that need to be in place in order to achieve that would be, work, people, opportunity, agency, practice. Secondary drivers related to those, sense of accomplishment or resources with work. For people, managers, colleagues, valuing people, opportunity, training and development, promotion opportunities, agency practice. And then you again would attach change ideas to each of those areas. So that's sort of a quick overview of when you're thinking about plan, do, study, act, some tools that you can use in that planning stage: an aim statement, a fishbone analysis, and a driver diagram. As I mentioned, or as you saw in a previous slide, there are a ton of planning tools that I'm sure you're already familiar with, like process maps or SWOT analysis. Absolutely use those if they're relevant to your QI, action plan, but I at least wanted to offer something new and different. So give it a shot, and I hope it works out for you and with your team. The next part of PDSA is the do stage. So during the do stage, we're testing out our action plan. So because you've already identified change strategies by using your fishbone and your driver diagram, you're now going to take those change strategies and incorporate them into a QI action plan. You're also going to, as you're monitoring your change strategies or your change efforts, you're going to identify which data you're going to connect to these change strategies in order to understand whether or not your QI plan is successful. And remember, when you're analyzing the data, you're measuring to learn, not to judge. Okay, I always say that. So when we're creating our action plan during the do stage, It truly is an organized action plan. You're not merely just meeting with your QI committee members and sort of brainstorming ideas, and then you kind of walk away. And then you meet again, and people say, well, what did we say we were doing at the last meeting? Who was supposed to do that? Wait, what are we doing? What's going on? A QI action plan truly allows for people to come to the table and organize specifically who is doing what by when. It should not be a long narrative document. It shouldn't just be a discussion, broad-based discussion. Rather, you're coming to the table and creating a robust, substantive, meaningful QI action plan. I will again provide this handout and template, but here's an example of what CCNY utilizes. On the left-hand side of your screen, you can see it's in teal. That's intentional. You'll see that the items bold in teal really specifically define the plan, do, study, and act portions of your QI plan. So it allows for a big picture overview of your PDSA cycle specific to this project. On the right-hand side in blue is really sort of the nitty-gritty, what specifically your team is going to do to, regarding this PDSA cycle. So again, the left-hand side in teal is the big picture overview of what it is you're trying to accomplish with this particular project. The right-hand side is sort of a much more narrow focus with specific strategies and action steps of who was doing what by when. Another way that you can manage a QI project is simply using an Excel spreadsheet, but the idea here is that you're documenting what your action plan is with specific tasks, so that when you are managing your PDSA cycle and your committee comes back to the table, you are reviewing specifically who is doing what by when. And you're connecting that data that you're monitoring along the way to those particular tasks. Is it in fact working? Because as you're documenting and as you're reviewing, if it's working, then continue with your PDSA cycle. If it's not working, meaning you're not getting the data you thought you'd get or the outcomes you thought you would get, it allows you to go back and sort of plan again. Go back to the planning stage and plan again. This is another example. Again, I just wanted to show the importance of documenting PDSA and how it guides your committee on who's doing what when. I'll do the second row, increased depression screenings for patients with chronic pain and or substance abuse. Sort of as they took a deep dive and trying to understand the problem, they realized that patient surveys revealed that they felt uncomfortable completing a depression assessment in the waiting room. So during their due stage, what are some changes that we can implement? We can conduct the screening in the exam room prior to being seen by the physician. We can train the room staff to conduct a PHQ-2 and a PHQ-9 as appropriate. And as we study that, what are the metrics we're going to study to see if in fact that does in fact work? We're going to look at the percent of screenings completed in the waiting room versus the exam room. We're going to collect improvement in patient feedback about screening processes. The goal here is no matter what, as you're implementing PDSA, you have a plan in place, a written plan in place that not only identifies the change strategies you are going to implement, but also the metrics you're going to monitor as you're implementing this PDSA cycle. Almost done, hang in there. Finally, as part of when we're talking about PDSA and we're considering the due cycle, I talked about collecting data, that you're collecting data, you're matching data to the change strategies because you want to assess whether changes occurred. It allows you to look at information over time. Remember, if it's not measured, it can't be improved. When you're thinking about metrics to attach to your QI strategies, consider both qualitative and quantitative data. Think about outcome metrics, process metrics. Consider time series analysis. So when you're monitoring your change strategies, you're sort of plotting along whether or not that particular outcome is getting better as you implement these new change strategies. As you plot it and you're working with your team, you can see, you know what, we're going in the right direction. Still, it's been a couple weeks or 3 weeks or 4 weeks and we're not going in the right direction, or we've plateaued. That triggers your team to say, whoop, let's go back. Let's go back to the planning cycle and see if we need to do something differently. When you're thinking about your QI project measures, obviously the easiest thing to do is think about the metrics you already have. So think about metrics that you already have in place that you can connect to your change strategies. If you don't have metrics in place, you may just want to think of essentially, creating a numerator and denominator to find the percentage. So, the idea here is the easiest thing to think about is, what do we have data already on, so that we can monitor our improvement. But if not, create a simple numerator, denominator, and percentage. Keep it simple. Keep your data simple. And I want to show you, I know I'm almost out of time here, but as you're studying your data and we're talking about plotting it along, this would be an example of when you're using a particular metric and you're plotting it along. So you have your baseline data to the left. You can see, as you're looking at this particular run chart, when the new schedule is introduced and how their data did in fact show a shift as a result of their QI changes. So when you're studying your data during the PDS, you're in your study phase, this is an example of how you would track and monitor your data in order to understand whether or not your improvement or whether or not your action plan was in fact an improvement. If it is an improvement, go ahead and act on it. Doing PDSA allows for you to have a small pilot. If the pilot does in fact work, go ahead and act on it. If it's not successful, then return to the plan stage. And that's that concept or idea of rapid improvement cycles. It allows for you to go back to the plan stage and rethink what it is you're trying to achieve. And so finally, when you're acting on your improvement plan, just make sure that you have your organizational process in place, your culture is in place, your planning in place in order to sustain that change. Oftentimes we know that when you do QI projects and then you give it to your team to implement, they go ahead and implement, and maybe, months down the road, they sort of revert back to old practices. It is imperative as a QI committee or as a QI director that you're sustaining and controlling for those improvements, that you don't let folks revert back to old practices, that you in fact are controlling and sustaining all of those improvements along the way. And in order to do that, you need to make sure you have your organizational processes in place, that you have a culture in place. And what I mean, I would just want to point something out, particular to the slide, culture and why it matters. It's not an accident. It's not something that just happens to the system. It truly is the way you implement quality improvement. It's a part of your business strategy. So if you're going to continue to sustain your change efforts and sustain your quality improvement initiatives, you're backed by an organizational process that allows for you to sustain that change. You're backed by a culture that in fact says, yes, this is important, and we will continue to sustain all of these changes by looking at this data on a periodic, continually basis. And we'll ensure that we have sustainability planning in place so that we don't revert back to old practices that got us, to underperforming at metrics. So I share this particular slide because here is an example of a driver diagram. And the aim statement here is to, in fact, ensure that managers create the conditions and effectively oversee quality control and quality improvement initiatives that maintain and improve system performance. That's the aim. The primary drivers in order to ensure that happens is that quality control management system is organized and in place, that they're able to manage quality improvement through coordinated projects, that they've established a culture of high performance management. So those three primary drivers are in fact in place in order to achieve their outcome. You'll see here in the secondary drivers all the processes and practices that need to be in place in order for that to happen. So I know I sort of rushed through the last few minutes here, but I at least one of my charge or one of my aims or goals for this particular presentation was to give you enough information and new information that allows for you to go back to your organizations and implement quality improvement in a continuous, meaningful, structured manner. And so when we're thinking about quality improvement, that it truly is a management philosophy, that it is embedded and woven into your culture, that you in fact do have a standardized quality improvement model, meaning that there's some sort of written policy and procedure, or there's a handbook on how the organization implements QI, what templates they use, what communication processes they have in place, how they report out on and market their QI initiatives, expectations around staff involvement and participation in QI projects. All of that is written in your QI model. That you're continually identifying and monitoring program outcomes, that you're not waiting for an audit to tell you that you're underperforming in a particular area, that you are looking at your program outcomes on a continuous routine basis, and that when those outcomes show that they've sort of decreased in a particular manner or not achieving their benchmark or their target, that you're able to execute a QI plan, hopefully maybe using PDSA, but a model to improve those outcomes. That you're not just sort of talking around the table and having a meeting and then walking away, but you're actually executing a meaningful, substantive, robust quality improvement plan that achieves the outcomes that you desire. So I see that we've got 3 minutes left. I hope that I was able to give you information and tools and templates that you can sort of think about as you go back to your organization today. Again, I'll provide those handouts to both Amy and Kathleen so you can have them to use at your leisure. So thank you very much. Certainly, if if anyone on today's training wants to call or email me for particular questions, I'm available. My email and my phone number is listed on the slide. Thank you.
Thanks, Christa. That was great. A lot of useful information I think we can all use and bring back to our organizations. And thank you all for participating in our session today. Amy has actually posted a few links in the chat. One is the evaluation. So if you could just take a quick moment to fill that evaluation out, that would be very helpful. She's also posted a link to our website. As we've said, great information. So we will have the slides, the recording, and those handouts posted to our webpage by the end of this week. You can also look at our webpage for future notices. So stay tuned for our July presentation, more information to come on that. And if anyone is interested in being a presenter, let Amy know, or if you have ideas for topics you'd like to learn more about, email her. Just checking to see if any questions came in the meantime here. No, just a lot of feedback for you, Christa. Thank you. Highly valuable information. A few people asked for the web page. Oh, I see Amy put that in the chat as well. All right. I don't see any other questions that came in.